I think we can start this session 6. This is an exciting session on sepsis in ventilated patients. As you know, lung is the main organ to react and to respond to sepsis. And we will cover this topic with 6 excellent speakers. And there is common characteristics of all of them. All of them are promoting the translational research, coming from the bench to the bedside, to try to discover or to understand better the pathophysiological mechanism and to discover new treatments. So the first presentation will be done by Michael Matthay. Michael Matthay is a professor of medicine and anesthesia at the University of California in San Francisco. He is an expert on ARDS and on biological mechanism and also on in cell therapy. So Michael, now is your time.
Thank you, Antonio. All right, so my topic is, thank you again, Antonio, and everyone else on the panel, the new global definition of ARDS, of which, as Antonio has already referred to, sepsis is the most common cause of ARDS, and of course, the lung is the most common source of sepsis in patients. These are my disclosures from NIH and other sources. There are no conflicts for this presentation. Now, I have 3 objectives. First, rationale. What is our rationale for expanding the definition of ARDS from Berlin in 2012? And secondly, to describe the recommendations for the new global definition of ARDS, and then to consider the clinical and research value of the new global definition of ARDS. So by way of brief review, I put a slide in to describe the Berlin 2012 definition, which we're all familiar with. This was an important advance, and the timing was emphasized 1 week of a known clinical insult. Chest imaging, bilateral opacities not fully explained by effusions, lobar lung collapse, or nodules. That the origin of the edema, specifically the respiratory failure, should not be explained by cardiac failure or fluid overload, and an echocardiogram could be used to exclude hydrostatic edema if there was no risk factor present. And then the 3 categories of oxygenation are described here: 200 to 300 for mild, 100 to 200 for moderate, and less than a PF of less than 100 for severe. But the question is, should ARDS really be defined by the presence of an endotracheal tube with positive pressure ventilation? Even in the original publication of Berlin in 2012, the editorial by Derek Angus pointed out this limitation of the Berlin definition. Also, it's worth remembering that most studies of pathogenesis of ARDS in animal models have not been done in ventilated animals. Now, what has changed since the Berlin 2012 definition? Well, 3 main areas. 1, increasing use of high-flow nasal oxygen for acute hypoxemic respiratory failure. Secondly, recognition that the SF ratio is a reliable surrogate for the PF ratio. And importantly, recognition of limitations of the Berlin definition for resource-limited settings. So in the spring of 2021, Lorraine, Taylor, and I published this commentary in Lancet Respiratory Medicine, in which we raised the issue of whether it was time for reevaluating the Berlin definition, with a focus on whether high-flow nasal oxygen should be included, PF ratio, and other issues. And subsequently, over a period of several months, we organized a consensus conference. And I will show you the members of this group shortly. But when we first met, there was 100% consensus that the Berlin definition of ARDS needed to be updated. We established 3 major working groups to evaluate risk factors, timing, and extrapulmonary organ involvement, oxygenation criteria and measurement methods, and chest imaging. We had discussion by the entire group in 6 meetings, And at the end of the 14 months, there was 100% consensus on the recommendations I will show you. Importantly, there were also input from members of 21 critical care societies to broaden the information and the recommendations from this conference. We did not request formal endorsements because we knew that could take years trying to go through each society, but we did obtain input from members around the world. This is a slide to just show you the different members of the consensus conference. There were 32. We wish there could have been 50 or 100, but 32 seemed to be a number that worked in terms of us actually being able to have just enough people to deal with the issues, but also not too many. We were meeting, of course, by Zoom. Ironically, the pandemic had facilitated this. Now, the major goals of the Global Consensus Conference are listed here. Should intubation or non-invasive ventilation be required for a diagnosis of ARDS? Is the SF ratio an adequate substitute to the PF ratio for assessing hypoxemia? And can ultrasound be used for chest imaging to identify the presence of pulmonary opacities? And I'm just showing you on this slide an example of a patient who did not meet the Berlin criteria of ARDS, but I think we would all agree really does have acute lung injury and ARDS. This was a 54-year-old woman, COVID-19 positive for 10 days, with 6 days of progressive shortness of breath and dry cough. Her oxygen saturation was 72% on room air. She was admitted on 6 liters oxygen, given dexamethasone. She had progressive oxygen requirement. She was transferred to the ICU where she was treated with high flow nasal oxygen with 60 liters with an F5 of 0.8. Oxygen saturation came out at 94% and the SF ratio was 118. I think we'd all agree this woman had ARDS, but not by the Berlin criteria. So what are the pros and cons, briefly, of adding high flow nasal oxygen equal to or greater than 30 liters immediate to the ARDS definition? Well, briefly, the advantages are focuses on patients requiring high levels of oxygen and low levels of PEEP, regardless of the presence of an intratracheal tube. We do know that high flow at this level does generate some PEEP. It accounts for the evolution of clinical practice around the world with the use of high flow. It would facilitate enrolling patients in trials at an earlier stage. And the endpoints can include progression to intubation if you allow patients to be identified at this point. And it facilitates studies of early ARDS and an ARDS natural history. What are the disadvantages? Well, it may be challenging to estimate the FiO2, although the FiO2 was successfully calculated in the FRAP trial, the original French trial, showing the benefit of high flow nasal oxygen in terms of mortality and intubation. Is the cutoff of equal to or greater than 30 liters per minute optimal? Well, we discussed that. Should it be 20 liters or 30 liters? We thought 30 liters was reasonable. We might include patients with better clinical outcomes than the Berlin definition. Indeed, that's the case, but that might be valuable. And what can we do in resource-limited areas where high flow is not available? What are the pros and cons of adding the SF ratio to the ARDS definition? Well, there are several advantages: continuously available, highly sensitive for hypoxemia, easily interpretable, non-invasive, no risk for procedural complications, and more readily available in resource-limited settings and outside the ICU. Disadvantages are measurement errors increased by poor perfusion, vasopressor, severe hypoxemia, or acidemia. There is a potential for misclassification of diagnosis or severity in ARDS, and of course, a potential for reduced accuracy in patients with darker skin pigmentation. Next topic, should ultrasound be allowed for the detection of bilateral opacities? Well, it does have good diagnostic accuracy for alveolar filling and consolidated lung in patients with ARDS. Bilateral worsening or loss of lung aeration defined by equal to or greater than 3 B lines per image between 2 ribs and or consolidations seems to be well established. And here are 4 references, including an excellent commentary by Lorraine in the Blue Journal last year on this issue. So on this slide, I'm summarizing the primary recommendations for the global definition of ARDS. First, we wanted to retain the conceptual model from Berlin with some very minor modifications. 2, expand the Berlin definition to include non-intubated ARDS with either non-invasive or high flow with a minimum flow rate of 30 liters per minute. Third, add the SpO2 FiO2 ratio as an alternative to the PF ratio for the oxygenation criteria. Fourth, allow the use of ultrasound with a well-trained operator to diagnose bilateral opacities, primarily for resource-limited settings. And finally, apply the Kigali definition of ARDS published by Beth Riviello in resource-limited settings, including oxygen saturation criteria, and not require minimum flow rate of oxygen or inexpiratory airway pressure. And this is as it's presented in the article in the Blue Journal. And you just notice there are three categories here: non-intubated ARDS, intubated ARDS, and the modified definition for resource variable areas. And I'll just highlight that those criteria right there. And then I'm just going to show you how they apply in the intubated ARDS. It's the same as Berlin, except we've added the SF criteria. And here's the non-intubated ARDS, now allowing high flow nasal oxygen or non-invasive with the same PF or SF criteria. And there is, in green on the far right, the modified definition in resource variable settings. And this figure just gives 3 examples to illustrate these 3 categories. The top is a patient who's intubated and ventilated with classic ARDS, moderate severity, with abdominal sepsis. The middle panel is a 54-year-old woman, as the one I showed you, who has high flow nasal oxygen. She's not intubated, but has ARDS. And the bottom is a 39-year-old woman with abdominal sepsis and gram-negative bacteremia in a small under-resourced hospital without blood gases, radiography, or mechanical ventilation. But her ultrasound shows the B lines, and her supplemental oxygen is being given by face mask at 15 liters, and she clearly meets the criteria. So finally, the potential benefits of the global definition of ARDS are summarized here. First, allow earlier recognition of ARDS by clinicians. Second, stimulate academia and industry to test therapies for ARDS at an earlier phase of lung injury. 3, stimulate research overall to test for reliability, feasibility, and validity. 4th, enhance studies of clinical outcomes after ARDS by including patients at an earlier time point prior to intubation. 5th, biology studies will be done at earlier time points, helping us to provide more insights into pathogenesis. And finally, we hope it will stimulate much more global research on pneumonia, sepsis, and ARDS. Thank you very much.
Thank you, Michael. Two quick questions that it didn't clarify during the last 5 definitions during the last years. Is first, because ARDS is a lung inflammation. Do you think that we need to include any biological parameters to identify the inflammation in the lung?
Yes.
Yeah.
Well, for that question, briefly, I wish we could, because it would be a very excellent way to try to quantify or semi-quantify the degree of inflammation in the early phase. But we don't really have a method yet for doing that, either by measurements in the blood, the plasma, or some other approach, unlike acute myocardial infarction, where we measure troponin. So we don't have that yet, but of course, I think many of us think, including you, that adding biology to ARDS, particularly in a research setting, is very important for pathogenesis and finding new treatments.
Michael, can you comment something about the potential effect of the PEEP, the level of PEEP, and especially on the if these criteria are sustained or are not sustained along the time? I mean, for example, there is the Jesus Villar studies that demonstrated that the physiological alteration should be sustained during the first 12 hours, for example.
You mean, I'm sorry, can you just say that again? You
I mean that if you have a patient, imagine with 5 PEEP, that is quite common in high flow,
right?
oxygenation, and then you increase the PEEP to 15, and the gas exchange will change.
Right, right. Well, very good point. Absolutely. I think all of us recognize that the PF or the SF ratio will often improve with higher levels of PEEP. Of course, with high flow nasal oxygen, as you indicated, at 30 liters, it's probably about 3 to 5 centimeters of water. Some variability depending on whether the patient is mouth breathing and other factors. I think that in clinical studies, if the oxygenation improves the higher levels of PEEP, that doesn't mean the patient did not have ARDS. If the initial measurement shows a PF or SF ratio within range, it's still is a patient with ARDS, but the oxygenation is being improved with the higher PEEP level, or possibly going to a prone position.
Okay, so thank you very much, Michael. I think we need to move to the next speaker. The next speaker is Lieuwe from Amsterdam University Hospital. Lieuwe is an expert on phenotypes and also on the mechanism, the pathophysiological mechanism of lung inflammation. And I'm sure Lieuwe will give you a new view on the mechanism of alveolar or lung inflammation in these patients. Lieuwe, is your time now.
Thank you very much, Dr. Artikas, and thank you for the invitation to speak here. So I'm going to speak about alveolar inflammation in ARDS particularly, but maybe in pneumonia more specifically. So we all know this figure that has been represented in multiple New England Journal articles with reviews on acute respiratory distress syndrome, where on the right side you see the different pathophysiological processes that are involved in the establishment of ARDS in specific patients. And what you can see is that the alveolar space is much more important than the systemic compartment in such illustrations. And I think we frequently forget that in clinical studies. And one of the reasons maybe is that it's just difficult to obtain those materials. So what I will do in the next 12 to 15 minutes is try to show you what you can do when you do reach those alveolar spaces, obtain those materials and analyze them in large quantities of patients, or using deep phenotyping, show the different immune compositions within the lung. So the primary point that I would like to make in this presentation, that is probably the most important point to keep in mind when talking about this problem, is that alveolar and systemic inflammation are indeed distinct. So on the left upper corner, you see a normal alveolar space, a normal capillary with very little inflammatory response. And on the right lower corner, you'll see the combined alveolar and systemic inflammation that we imagine in most of the cartoons about ARDS. But based on clinical studies and animal models, we know that one can have exudative alveolar edema with only vascular inflammation or predominant vascular inflammation, or only with alveolar inflammation. And this is probably a heterogeneity that we also would like to observe in the clinic. So I'm going to speak with you first about a cohort from Amsterdam with COVID-19 patients admitted to the ICU with ARDS, where we performed multiple bronchoscopies with bronchoalveolar lavage and measured protein biomarkers at multiple time points. In this study with about 200 patients and about 500 bronchoscopies, we saw that the concentration of many of these inflammatory markers was higher in the alveolar space, depicted by the blue dots in the most left figure. All of these markers were higher in the alveolar space despite the dilution of the bronchoalveolar lavage fluid, and were associated with primarily neutrophil and macrophage interactions. When we then modeled those biomarkers over time in figure B in the middle, we saw that the concentration of many of these biomarkers increased over time in the alveolar compartment, depicted by the green dots on the right side of the graph. This is in contrast to biomarkers in the systemic compartment, which frequently drop during the first 4 days of ICU admission. When we then modeled the association between the change in the biomarker and mortality, shown in part C of this figure, we saw very large associations between several of these biomarkers and mortality as the outcome, as most pronounced with CCL20 and CXL1 and TRAIL and CCL2. If we look back at that figure that I showed and we zoom into those macrophages and neutrophils in the lung, you will see that many of the markers that are described in the review articles are indeed found in this study in the alveolar space, but may not have been found in the systemic compartment. Therefore, I would like to make the controversial statement that in ARDS and in pneumonia, plasma is probably the trash can of the lung and is indeed not the compartment we're interested in. When we look back at these patients, with on the left side the graph that you just showed for the alveolar compartment, and looked at these same biomarkers on these same time points in the same patients in the plasma compartment, we could find either smaller associations between the biomarker and the outcome and mortality, or even contradictory associations, for example, for TRAIL and EGF, where the increasing association in the alveolar compartment was associated with the higher mortality, but the decreasing concentration was associated with the higher mortality in the plasma compartment. So now I've been talking about protein biomarkers, and I would like to spend some time on cell types as well. So we're just talking about neutrophils in ARDS, right? If you read the textbook about ARDS, it frequently talks about neutrophils being the most important cell type in ARDS. And indeed, they are the most abundant one, but are they also the most important one? In this review, just submitted by Shichi Zhang from Amsterdam now, she compared all the literature that has been available on early and late stage ARDS between patients with a favorable and an unfavorable outcome. As you can appreciate, indeed, the neutrophil is the most abundant cell type in the start of the inflammatory response, mostly immature and mature neutrophils. You can also appreciate that the difference between patients with worse or better outcomes is not that large in the start of the ARDS. In the later stages, which we defined after about 72 to 96 hours on the mechanical ventilator, a persistent hyperinflammatory response depicted by immature neutrophils or mature neutrophils was associated with worse outcome, while a switch to a more M2 type macrophage response was associated with better outcomes, showing that it's in those patients who remain on the ventilator for a longer period of time, it is the adjustment of the inflammatory response that is very important. And there is an important interaction between all of these cells. So we cannot see the neutrophils in isolation. There is a very close interaction between macrophages and neutrophils, but also an important role for the T cells and the memory T cells to stimulate the adequate responses on the inflammatory response and to guide the inflammatory response towards a more recovery phase. I would like to shortly talk about a very interesting paper that has not been published yet, coming from the group of Caroline Calvi from San Francisco, that she allowed me to share with you some preliminary results looking at tracheoaspirates and bulk and single-cell RNA sequencing in hypo and hyperinflammatory ARDS patients. In this work from Dr. Sarma, He compared alveolar gene expression molecular patterns between these two important phenotypes, showing that, like we already know happens in the systemic compartment, also in the tracheal compartment, there are strong inflammatory differences. Using single cell analysis, bringing this back to different cell types, he was able to show that the T cell, depicted in red on the right, has an important role in orchestrating the other cell types in the lung, and is probably a key cell type in influencing the responses of the alveolar macrophage and the neutrophil. Furthermore, he was able to show that the neutrophils and lymphocytes in hypo and hyperinflammatory patients have very different molecular phenotypes. And this might be another point that could be interesting in the near future, now that single cell analysis is much more available. So to look more at that that heterogeneity in the alveolar space, I just want to mention two preliminary findings, one coming from the COVID patients that I just mentioned in the first example. In this study, we used the same phenotyping techniques that are available for plasma biomarkers and that resulted in the hypo and hyperinflammatory subphenotype, but used them on the alveolar materials. And we were able to show that also in the alveolar material, there are two subphenotypes of ARDS, one with more hyperinflammatory response and one with a more hypoinflammatory response, and that these did not agree with the plasma biomarker responses. These biomarkers were most important, where there again were the same biomarkers that were associated with worse outcome in our previous analysis, with CCL20 and IL-6 being the most clear abundant ones. This is actually, this was in ARDS due to COVID-19. It actually replicates findings by another group published 2 years ago in Critical Care Medicine, showing that two phenotypes exist based on alveolar samples taken from patients included in an ARDS randomized controlled trial, where also IL-6 was the most discriminating biomarker between these two subsets, suggesting that this might be replicable across cohorts. So to conclude, I think I was able to show you that alveolar inflammation is probably important, that it does not always correlate with systemic inflammation. And I think that is important for what we can do with immune suppression and immune stimulation in patients with sepsis. In this very nice article from Conway Morris in ICM 2 years ago, they described the potential impact of immune suppression or immune stimulation if the two compartments were not concordant. So in the discordant states, which seems to be quite common in ARDS patients, it's completely uncertain what the impact of either suppression or stimulation could be. And it means that we need to understand this much better in order to guide our immunomodulatory treatments. So the take-home messages are: alveolar inflammation is not the same as systemic inflammation. No, it's not just the neutrophils. You have to look broader than that. And compartmentalization makes immunomodulation very difficult. And I think we need to learn more, and now we have the techniques to do that. So with that, I would like to take any questions.
Thank you very much, Lieuwe, for this excellent, interesting presentation. That is in a little bit in opposite of the previous one, that the general new global definition probably needs to have a more precise information on the biological lung changes in these patients. So my question is, do you think that it's necessary to have a look on the time evolution of these patients from the biological point of view?
So I actually think that is critical. So what would be an essential mistake is to group all the patients together in the different phases of the ARDS. So what we have shown in that review that I showed two figures from is that what can be beneficial at the start of ARDS can be detrimental in a later phase. So I think in the early stages, the neutrophilic inflammation in the lung is probably suitable and is necessary to make sure that, for example, the pathogen is eliminated. But if it persists after 3 to 5 days, it's probably not as beneficial anymore, and it might be necessary to temper it. And I think we frequently forget the dynamics. And I'm sure that this is not only true for the alveolar host response, but also for the systemic host response. And one of the interesting articles that will be coming out hopefully soon is that if you look at phenotypes over time and you reassess the inflammatory state after 2 days, after 4 days, and after 6 days, patients will switch from a more hyperinflammatory to hypoinflammatory state. And that switch is actually the most predictive of the outcome of the patient, much better than anything that you can measure at baseline.
For your point of view, what will be the future? Because, your recommendation is to do BAL samples in these patients, or tracheal aspirates, or other techniques that could be less invasive for these patients?
So personally, I believe that if we are able to show that you could improve patients' outcomes by doing a bronchoscopy with a BAL, nobody would have a problem with doing that kind of diagnostic technique. In our hands, it has been very safe to do it, but it needs experience. And that is probably the factor that limits application at the moment. Also, we are unsure whether doing a bronchoscopy would actually improve the outcomes at the patient, because now it's mainly for obtaining microbiological samples. I think tracheal aspirates are an inferior alternative for assessing alveolar inflammation, but of course are easier to obtain. And the group from Lorraine Ware has developed a heat-moist exchanger analysis that is quite interesting, that we try to use here as well. And that would be very interesting to develop further, although it does require a very specific heat-moist exchanger, and not every type of model can be used for that. So there's also a implementation difficulty with that kind of technique. But if it could replace the BAL, that would be fantastic, and that could provide us with an opportunity to study the alveolar space better.
And for the analysis of the XL air, because you are an expert on this area.
Yes, so I spent 10 years of my life studying that concept, and I'm afraid that I currently think it's not as good a reflection of the alveolar inflammation that I had hoped for.
Okay, so thank you very much, Lieuwe, for this excellent presentation. And just to be on time, we move for the next speaker. Next speaker is Lorraine Ware. She's professor at the Vanderbilt University. And Lorraine, she's an expert on biomarkers. And we will have her view of biomarkers in ARDS and sepsis. I don't know if these are biomarkers from the systemic samples or from the lung. We will see.
Thank you, Antonio. So I am going to talk about systemic biomarkers in ARDS and sepsis, which apparently are coming from the trash can of the lung, which is an interesting thought. But I'm going to focus on systemic biomarkers because I think, at least at the moment, these are the most accessible biomarkers at the bedside that we might be able to rapidly implement in clinical care. And I'm just going to focus in this brief talk on 3 areas. First, I'm going to talk about some of the challenges that we've faced in biomarker development in the clinical syndromes of ARDS and sepsis, and then talk about how systemic biomarkers have been used to approach heterogeneity in these clinical syndromes, and then finally briefly talk about clinical implications. So I've been working in this field for several decades, basically trying to identify the troponin of the lung. And there are tremendous challenges in this endeavor related both to tissue complexity and syndromic complexity. So in acute cardiac syndromes, we've had the field has had lots of success. We have several single biomarkers that are very useful in acute cardiac syndromes, including troponin and B-type natriuretic peptide for both diagnosis and prognosis. And I think the success in these cardiac syndromes is driven in part by the fact that the heart, although not a simple organ, at least is predominantly made up of a single cell type, the cardiac myocyte, that can provide strong signals when it is injured. When we think about the lung, there is no single predominant cell type. There are multiple cell types, and in acute lung injury, multiple pathways that are dysregulated, leading to many, many potential biomarkers and no single predominant biomarker. And then if we consider the most common cause of acute lung injury, sepsis, this clinical syndrome, of course, is a multi-system disorder with involvement of multi-organs. So it is no surprise that we have not yet, and probably never will, identify a single biomarker that will be useful for diagnosis of these complex clinical syndromes. So just to focus in on the lung for a moment, this slide summarizes some of the cellular sources of biomarkers that have been studied for diagnosis and prognosis in ARDS. And you can see there are many potential sources of biomarkers. There's injury to the lung epithelium, leading to release of lung epithelial biomarkers such as surfactant proteins, RAGE, and club cell 16. Injury to the endothelium, leading to release of endothelial injury biomarkers. And then activation of inflammation, coagulation pathways, and profibrotic pathways. And this all leads to a great variety of biomarkers that have been studied in ARDS. And there's also a lot of overlap systemically in the biomarkers that have been useful for prognostication in ARDS and understanding biology with biomarkers that have been identified in sepsis in the plasma. And in fact, it's really only been lung epithelial biomarkers systemically that have been useful for differentiating ARDS in patients with sepsis. So just as an example here, this is the performance of a biomarker panel of 3 lung epithelial injury markers, SPD, RAGE, and CC16, along with a couple pro-inflammatory cytokines, showing that there's reasonably good performance of this panel in differentiating sepsis patients with ARDS from sepsis patients without ARDS, particularly for those with the most severe ARDS, where the area under the curve was 0.82. So we're certainly still a long way from having any biomarkers that we could implement at the bedside for diagnosis or prognosis in ARDS. And I do think this relates both to the complexity and heterogeneity of these clinical syndromes. So how can we harness this biological complexity to better understand these clinical syndromes? Well, I want to focus on how biological markers have been used to understand biologically distinct phenotypes within ARDS and sepsis. And so how can we take this clinical syndrome that encompasses a great deal of heterogeneity and somehow parse this into more homogeneous subgroups that we might treat differently at the bedside? This has been an area of interest for over a decade in the field, and I'm going to focus predominantly on the work of the Calfee group at UCSF, who's applied latent class analysis, which is an unbiased modeling approach that is based on the hypothesis that within a group, for example, of ARDS patients, that there may be a number of identifiable, more homogeneous classes, such that if this is a group of ARDS patients represented here, the LCA analysis asks whether there are identifiable subgroups hidden or latent within that larger group that can be identified through this analysis. So this is the first study from the CALFI group applied to 2 early ARDS-NET clinical trials using biological markers from the plasma and clinical characteristics. And what Carolyn found is that there were indeed 2 latent classes within the patients in these clinical trials. And they were distinguished predominantly by the characteristics at the far ends of this graph on the x-axis, which were predominantly plasma biomarkers of inflammation, which led to these classes being called hyperinflammatory and hypoinflammatory. And these classes had different mortality, with approximately twice the mortality in the hyperinflammatory group. Carolyn went on to reproduce these classes in multiple clinical trial populations independently, and then in some observational cohorts with ARDS, showing that these 2 classes show up reproducibly across all these cohorts of patients. And then more recently, working with Pratik Sinha, we repeated this analysis in 2 cohorts of patients with sepsis, patients who, many of whom did not have ARDS. And again, in a de novo LCA analysis, found 2 classes that were separated by the same characteristics, and most predominantly by plasma biomarkers of inflammation. So this suggests that these 2 phenotypes or classes of ARDS are not just common to ARDS, but seem to cross critical illness clinical syndromes, including sepsis. And so these 2 phenotypes, quite robust, and may represent an opportunity for enrichment of clinical trials and care at the bedside. So I'll just touch on that in the last minute here. How could we harness this biological information to better take care of our patients? So I think there's 2 opportunities here. One is for prognostic enrichment, where we use these phenotypes to select patients at higher risk of poor outcomes, such as the hyperinflammatory phenotype, to enrich trials for poor outcomes and reduce the number of patients needed to be enrolled. And the second opportunity is for predictive enrichment, to select patients more likely to respond to a therapy. So some of these ideas have already been applied retrospectively by the CALFI group. In several clinical trials, the hyper and hypoinflammatory phenotypes have had differential treatment response to the therapies tested, including high versus low PEEP in the Alveolar trial and conservative versus liberal fluid therapy in the FACT trial. And then in pharmacological therapy trials, this is data from the HARP trial from Danny McCauley's group. And looking retrospectively at the hyper and hypoinflammatory groups, you can see that the hyperinflammatory group in red actually had a survival benefit from simvastatin, which was not apparent in the overall trial and which was not seen in the hypoinflammatory group in blue. And then more recently in sepsis, this is a reanalysis of the PPAHS shock trial, which you may recall was a clinical trial of activated protein C in patients with severe sepsis and shock that was overall a negative clinical trial. And here again, we can see in this retrospective analysis that patients in the hyperinflammatory group had clinical benefit from receiving activated protein C in terms of survival, whereas in the hypoinflammatory group, there was actually evidence of potential harm from activated protein C with lower survival in the treated group. So this is all retrospective data. There are some current barriers to using LCA phenotypes in clinical trial design. First of all, it's unclear in what way these phenotypes may be treatable traits, and at the moment we're driven only by retrospective data. There are also challenges to identifying these phenotypes in real time at the bedside, although we're making progress in bedside biomarker assays. And the Panther platform trial, which is a multinational clinical trial platform, is going to advance this concept into clinical trials shortly. In the meantime, I'll just conclude by asking whether there are any mechanistic biomarkers that might be used as treatable traits as single biomarkers. And I don't have time to go through all of these, but I'll refer you to this nice figure from an article from Danny McCauley's group. And this just shows a number of potential biomarkers that might be used to enrich trials of that target the particular pathway that the biomarker marks. And just for example, IL-6, if elevated in patients with sepsis or ARDS, could be targeted with IL-6 inhibitors such as tocilizumab, something that was fairly successful in the COVID-19 pandemic. One marker that's not on this slide is cell-free hemoglobin, which is elevated in the circulation in sepsis and ARDS, and can be targeted with acetaminophen, which is a hemoprotein reductant, specifically targets free hemoglobin. And this was recently done in a pedal network trial that was recently completed and will be presented at the American Thoracic Society meeting in May. So I'm going to finish there and just say that although we are not ready to implement biomarkers in ARDS and sepsis at the bedside to guide our care, I think we're getting much closer, and that the use of biomarkers in guiding care is coming soon to a bedside near you. So thank you.
Thank you very much, Lorraine. Just two quick questions, because you are an expert on blood coagulation and platelet activation. Do you think that what is the role of the blood coagulation alterations in these patients? And do you think that is a target to treat or to try to improve the patients?
Yeah, I think that's a really good question. And certainly our biomarker studies, both in the plasma and in the airspace, indicate that there's quite a lot of dysregulation of coagulation and fibrinolysis in the lung in ARDS and systemically in sepsis. But to date, we have not had a lot of success with a variety of clinical trials targeting these pathways with a variety of agents. I do think that the data from the reanalysis of the PPAHS shock trial that I showed you suggests that perhaps we need to target these therapies better to patients who are more likely to benefit. Although retrospective analysis of PPAHS shock looking specifically at activated protein C levels did not indicate a group that was more likely to benefit. So there's a lot of complexity, and I just think we need more work before we're going to be able to understand who actually might benefit from these therapies and whether we need to deliver them to the airspace or systemically.
Another quick question for you is the classification of the different subphenotypes that can be used in different trials to try to identify more homogeneous population to test a new treatment. Sometimes it's difficult to know what is the time zero when they start sepsis. And my question is, do you think that the identification of the different subphenotypes that has been done during the first hours of the ICU admission or hospital admission, do you think that these subphenotypes will change after 2 or 3 days, and probably this strategy should be different?
So I think that we definitely need more study in this area, and I think the data that Lieuwe referred to that has not yet been published will be informative in regard to phenotypes changing over time, and this is going to be studied quite in depth prospectively in the NHLBI ARDS Pneumonia and Sepsis Consortium, which is about to begin enrolling 4,000 patients with ARDS, sepsis, and pneumonia, and doing serial sampling of both the alveolar compartment using HME filters and plasma over the course of illness. And we'll be able to really much more definitively answer that question in a very large patient population. So more to come on that question.
Okay, so thank you very much, Lorraine. Just to keep you on time this session, and we will move forward. The next presentation will be done by Carmen Barbas. She's professor of pulmonary and critical care at the University of Sao Paulo in the medical school. And Carmen she's an expert on mechanical ventilation and also on pathophysiological mechanisms of acute lung injury. And I'm sure that Carmen will give us a new view on the unraveling the enigma of genetics and phenotypes in sepsis and ARDS. Carmen, it's your time.
Hello, thank you for the kind invitation for this meeting. And I'm talking about the unraveling the enigma of genetics and phenotypes in sepsis and ARDS. I have no conflict of interest regarding this presentation. First of all, I'd like to emphasize the concept of ARDS. That's a term applied to a spectrum of conditions with different etiologies, which share common clinical pathological characteristics. Increased permeability of the alveolar capillary membrane, resulting in inflammatory edema, increased lower rate lung tissue, resulting in low lung compliance, and increased shunt and dead space, which result in hypoxemia and hypercapnia. The increase in the pulmonary vascular permeability index leads the extravasation of the plasma from inside the capillaries to the alveolar space, flooding the lungs with a liquid rich in protein that increase the weight of the lungs and leads to compressive atelectasis and a lot of collapse in the gravity-dependent portions of the lungs. This increase in the weight in the compressive atelectasis will result in the increased shunt, a decrease in compliance, a decrease in PaO2, FiO2, and an increase in dead space and ventilatory ratio, and increase in PaCO2 in the more severe cases that is associated with a poor prognosis of these ARDS patients. Among the risk factors of ARDS, pneumonia and sepsis are the most common ones. The literature described recently subphenotypes of ARDS, the hypoinflammatory and the hyperinflammatory subphenotypes that are related to different clinical and laboratory parameters. And these different phenotypes is different in predictive and prognosis enrichment, and the hyperinflammatory has a higher mortality and different responses to different strategies, the endotype response. Recently, Hu and colleagues described 3 phenotypes and lung microbiota signatures of immunocompromised patients with pneumonia-related acute respiratory distress syndrome. They characterized 3 clusters of patients, ARDS patients, these immunocompromised patients, with different 3 subphenotypes with different clinical and laboratory data, and they showed different curve survivals related to these different subphenotypes, and these 3 different subphenotypes have different microbiota signature revealed by the metagenomics. This is the different microbiota signature in the different subphenotypes, and they associated these different microbiota that have positive and negative contributions to the different subphenotypes. So in the intensive care medicine issue of December 2023, Professor Antonio Artigas, Professor Michael Matthay and I authored an editorial unraveling the enigma of genetics and phenotypes in ARDS, and we comment about this robust article of genetic that identified genetic profile and biomarkers involved in acute respiratory distress syndrome by Kale and colleagues. Let's understand this robust genetic study. The authors used genome wide study that they separated thousands of traits of ARDS and no ARDS patients. The wide associated studies associated DNA banks or genomes with particular disease, so they can separate ARDS cases versus no ARDS cases. And they did, after they did Mendelian randomization wide association studies that analyzes behavior, environment, and how the organism reacts to a given disease. They detect thousands of traits and with no gene genotypes, different plasma proteins and blood chains. This is the identification stage of this study. Then they validate the study with peripheral blood transcriptome analysis of ARDS cases and no ARDS case, and they used transcriptome tissue of preclinical mouse model of LPS ARDS, and they validated 4 blood genes and 5 immune cells, and then the other stage is the application of these finds. They did a card online platform, and then they built a predictive model nomogram for ARDS. This is the association between the genes and the immune cells, the significant ones in the RDS case and no RDS control. And this is the risk prediction model, the basic one, and the addition of the 4 genes and the 5 immune cells. And then they showed the area under the curve of the basic model of predictive to predict the ARDS with an area under the curve of 0.7, and with the addition of the 4 genes and 5 immune cells, they significantly increased the area under the curve for 0.79. After that, there is another interesting study of Lee and colleagues that they studied ARDS and aging. They studied the genome banks of ARDS and the genome banks of aging people, older aged people, and they described the thymidylate synthetase. It's a gene that they related with the ARDS patients with sepsis that develop ARDS in septic patients, and they showed an area under the curve to predict the ARDS of 0.8. And then they described the signaling pathway network among the cells, among the endothelial cells, the fibroblasts, the macrophages, and the alveolar cells, the epithelial alveolar cells. And they concluded in this study that endothelial cell damage associated with aging could contribute to ARDS progression by triggering the inflammation. In conclusion, ARDS is a complex syndrome that's related to age. We have the most important causes in pneumonia and sepsis, and you have to study the immunological status of the patient that is different in the immunocompetent and immunosuppressed patient. We have a genetic background, of course, that expressed different phenotypes, most importantly the hyperinflammatory and the hyperinflammatory, that associated severity and the multiple organ failure lead to improvement in prognostic and mortality enrichment that have to be considered in the randomized future clinical trials. Thank you for your attention.
Thank you very much, Carmen, for your excellent presentation. May I ask you, do you think that because the age of patients that are admitted in our ICU is increasing, so do you think that this will change the incidence or the prognosis of acute respiratory failure in patients that are admitted in the ICU?
Yes, the older people or the aging patients have more ARDS, and the prognosis is worse in this population. We have to take it in account when we are taking care of these ARDS patients. And they are describing gene-related associated with age and with ARDS that is contributing to our understanding why the aging people develop more ARDS than the younger people. And maybe this endothelial dysregulation that can lead or trigger the inflammation and leads to the extravasation of the plasma through the alveolar space. It's interesting all this study because we are understanding better and better the physiopathogenesis of ARDS that will contribute to future studies and the comprehension, a better comprehension of this syndrome.
Do you think that the genetic information or the genetic profile will be important to identify those patients with a high risk to develop an ARDS and then to try to prevent this according to the different therapeutic strategies?
I think this will help us to understand that the genetic profile is important to the phenotypes expressions. Maybe in the future, we will have more available kits that to us to measure this gene or to see this the artificial intelligence is improve a lot of these informations, and you can have in the future the possibility to have the gene profile of the patients, the ICU patients, before they develop ARDS, to avoid secondary injuries and to treat better our patients.
Okay, so thank you very much, Carmen, and we move for the next speaker, that will be Pedro Povoa. Pedro Povoa is professor of medicine at the Nova Medical School in Lisbon. Pedro is an expert on pulmonary infections, and his talk is on the diagnosis of ventilated-associated pneumonia. So, Pedro, it's your time now.
Thank you, Professor Artigas, for the presentation and invitation. And now we are going to switch from ARDS to a complication of patients that are under mechanical ventilation, that is VAP. These are my disclosures related to nothing related to this topic. During my presentation, we'll cover these 4 topics: clinical manifestation, radiology, what biomarkers could help us, and then a little bit on microbiology. So concerning diagnosis, and the diagnosis is of VAP is something that appear after at least 48 to 72 hours of invasive mechanical ventilation, and we need to have at least a new or progressive infiltrate on the chest X-ray, and some clinical criteria that could be fever or hypothermia, that could be leukocytosis, leukopenia, changes in the volume and purulence of the secretions, and ideally we should have also a microbiological recommendation from a low respiratory tract samples or also from blood cultures. And we divide from epidemiological type of view the VAP in early and late VAP because there is some change in the microbiology when we have a late VAP from the early one. But we have several problems with these definitions and with VAP. VAP is an important and frequent complication in patients under invasive mechanical ventilation. Is the second most common hospital-acquired infection in the US, but is the most common severe hospital-acquired infection in the ICU. It is associated with lots of poor outcome measures like increased length of stay, increased duration of mechanical ventilation, increased costs, increased morbidity, and also increased mortality. But there are other things that happen to patients under mechanical ventilation that mimic VAP, like VAT, tracheobronchitis, pulmonary edema, pleural infusion, atelectasis, other hospital-acquired infection, and this makes the diagnosis difficult. And so we currently do not have a valid and reliable definition of VAP, and we need more accurate and objective criteria. But until that time, we have to use what we have. And these definitions include subjective elements like purulence of secretions that maybe you have one definition of other when looking at the secretion of the patients. And some are neither sensitive or specific. And the problem is that we don't have a gold standard diagnosis. And this is very important in an era of that we report the rates of hospital-acquired infections, and also we benchmark between ICUs. And the limitations of the definitions are different. So if we look at the different criteria from different agencies and societies, all of them would require a chest X-ray that lacks sensitivity for VAP. There is a wide inter-observer variability, and we intensivists are not experts in radiology. So we have sometimes difficulty in interpreting this exam. The clinical signs and symptoms have a good sensitivity but poor specificity, and they are highly subjective, as I just said, and the documentation varies a lot between people, between staff in the same ICU in different ICUs, between ICUs. And also the microbiologic evidence has a poor sensitivity but a good specificity. The practices vary a lot between different centers, and there is still controversy about what is the best practice. And if we look at the most recent management guidelines of HAP and VAP from the IDSA and ATS, one of the requirements to define pneumonia to have a new lung infiltrate. But if we look at the number of times chest X-ray is mentioned in the guidelines, and the chest X-ray is something that is important to define the new infiltrate, only 4 times. And why is that? Because maybe this is difficult to define what is a new infiltrate. If I show you these 2 chest X-ray, which one has new infiltrate? The one in the right, the one on the left, both? Sometimes it's difficult to know which is an infiltrate. And on top of this, the technical aspects of the chest X-ray also change what we see. And this is also something important to bear in mind when we are assessing this one of the criteria of VAP. And we know that the accuracy of chest X-ray is not that good. And if we compare to a CT scan, they show a poor sensitivity and also a poor positive predictive value. But again, it is impossible to CT scan to all of the patients, not only because of the availability of the exam, but also because of radiation. Concerning the other diagnostic criteria, that is the sampling of the respiratory samples, there is differences looking at the recommendations of the American guidelines and the European guidelines. The American is just to perform a non-invasive sampling rather than being treated empirically, obviously. But in the European, they recommend a distal quantitative sampling to reduce antibiotic exposure, improve accuracy of results. So this is related to the next step, the microbiology. And here is the definition we use affects a lot of the answer we get. If we look at this interesting study from Andrew Conway Morris, he looked at 53 patients with suspicion of VAP, and according to the way he sampled the patients and he assessed the diagnosis, comparing endotracheal aspirates with overdiagnosed VAP compared to a quantitative BAL, almost 4 times more, 87% versus 21%. And if we look at the BAL qualitative endotracheal aspirate and quantitative endotracheal aspirate, so all the same patients, the diagnosis of VAP with a microbiologic confirmation is 21%, with BAL is 87% with qualitative endotracheal aspirate and 51% with quantitative endotracheal aspirate. So the model the potential when he modeled the potential effect of VAP incidence according to the way we sample the patients, it predicted that with the use of BAL would reduce VAP diagnosis by 76% and antibiotic use by 30%. So this is very important data. Looking at what are the most important bugs, this is a study we performed almost 10 years ago, where the top 3 that represent almost 60% of the cases is MSSA, Pseudomonas, and Klebsiella pneumonia. And in a more recent study that was published last year by our group concerning sampling, was 2/3 of the patients with suspicion of VAP had a BAL. And here it changed a little bit, but again, the first one was Pseudomonas. The second was Acinetobacter baumannii, that was much more frequent than 10 years ago, but the centers were different. And then MSSA and Klebsiella pneumonia. And this represents more than 2/3 of the patients. What about biomarkers? And biomarkers can be helpful, not looking at a single value, but of the kinetics. This is a study that we performed with Professor Artigas and also Lieuwe a couple of years ago, looking at the kinetics or the changes of the value per day in patients under mechanical ventilation during the first week of mechanical ventilation, and not looking at the value of CRP, but looking at the slope, so the trend of change of CRP over time, have a good correlation with the risk of developing a VAP that was not observed with other biomarkers. And so a patient that has an average increase of CRP concentration of 1 milligrams per deciliter per day during the first 6 days have a more than 60% higher risk of having a VAP than a patient without a CRP increase. And we also did a calibration plot, and as you can see here, the higher the slope, the higher the risk. And we also look at the individual values at the day of VAP suspicion, but again, around 0.6, 0.7 of the area under the curve. So not as good at looking at the kinetics of the biomarker. And also the microbiology lab changed a lot. And now we have ways of identifying very quickly the pathogens that were identified in the cultures with the MALDI-TOF. So this is sort of a proteomics, where very quickly the quality gives you a spectra that is a sort of a fingerprint of the pathogen, very specific, very accurate, and inexpensive, that gives you the response of the pathogen much quicker than the usual cultures. And here is the use of the PCR panels. This is one of the panels that is currently available in some places, Pneumonia Plus panel, that has 27 pathogens, where all the pathogens that were on the top of the figure of the ENIRIS study are here. And so in a couple of hours, this could be available also with some antibiotic resistant genes that could be different from the phenotypic expression of these genes. So concerning the pros and cons of these methodologies, so they are easy and simple to use, they are rapid, highly sensitive, and it is important. It is a good thing that the prior antimicrobials do not affect the response, but they have a higher cost. They can also detect organisms that are not infected but are only colonizing. could have an overinterpretation of resistance because those genes could not be expressed, and also false negative results if the pathogens are not in those panels. And there are some data with bloodstream infections, but what is interesting in this systematic review and meta-analysis of 31 RCTs is that if you have the result, but this is not coupled with antibiotic stewardship program, there's no impact on outcomes. But if you have that information available quickly and coupled with antibiotic stewardship programs, it decreases significantly mortality. Recently has been published a single center, single blinded RCT using a syndromic pneumonia panel. And the endpoint was provision of pathogen-directed treatment based and also time to provision of pathogen-directed treatment. And as you can see, it is much faster using these rapid diagnostic tests to have a pathogen-directed therapy, but unfortunately without any impact on Lancaster readmissions and day 30 and day 90 mortality. So in conclusion, defining VP is complicated and challenging, may be useful also to follow a structured approach, not to forget anything, and to have good sampling and more accurate diagnosis. We need to monitor clinical, radiological, laboratory, and microbiology results, and only to collect them if there is a suspicion, and then to investigate. And is very important also to collect good samples. Thank you very much for your attention.
Thank you very much, Pedro, for your update on how to diagnose or identify VAP in patients in the ICU. I have a quick question for you. Can you say something about the differences among the different microorganisms? Do you think that the effect, especially on pathophysiological consequences of the different microorganisms, could be important to take in account in patients that with sepsis ventilated?
Your question is if different microorganisms can give you different clinical pictures. Is that correct?
Clinical pictures and also biological effects.
Yes. When we did some analysis, and also in the BioVap study and in the TAVEM study, trying to look at to cytokines and also some biomarkers, and we were not able to differentiate levels of biomarkers according to the different pathogens, and also just looking at gram-positives and gram-negatives. The only study I am aware where some biomarkers could be much higher in one pathogen is a study by the last author is Tony Torres. The first one, I think, is Garcia Vidal, I think. I can't remember exactly. That was published in Chest a couple of years ago, where people that were infected with Legionella pneumophila had a much, much higher CRP level, almost always above 25 than the other pathogens. But again, looking at the other pathogens, the level of biomarkers is much more related to the severity of the disease than to the pathogen itself.
The last question for you is, what do you recommend for the audience? Do we need to treat tracheal bronchitis or not?
Okay. So I as you know, I am a little biased on that. So I'm going to declare my conflict of interest on that, because I think tracheal bronchitis is a different clinical entity. And we have, in the TAVEM study, we have shown that they are different. They have, the people with the tracheal bronchitis have a similar mortality to people without that is under mechanical ventilation for another reason, but do not develop either a VAP or a VAT. But they have a longer duration of mechanical ventilation. So it seems that it has some impact on that. And we also show that if we don't treat it, there's a group of patients that evolve to VAP. So it could be a sort of a transition between colonizer, VAT, VAP, so tracheobronchitis pneumonia. In this more recent, the ENIRI study, what appeared from the patients that had tracheobronchitis, defined tracheobronchitis, the mortality was, we don't know why, higher than in the TAVEM study. And again, there was also a risk of evolving from VAT, tracheobronchitis, to VAP. Sadnesser has ended a trial on treating VAT with antibiotics versus no treatment, and he finished the trial, and I think he will publish the results soon. So we'll have the answer for that. And also in Brazil, Carmen maybe knows, Bruno Tomazini is going to run a trial also on tracheobronchitis being treated or not treated. And so these two studies, when finished, I think will help us to know exactly if it is a disease and if we need to treat it.
So that means that we need to wait for the results of this study. Okay, yes. So thank you very much, Pedro. And we move to the last speaker. The last speaker is Marcus Schultz. I'm happy to introduce him. Marcus is professor at the University of Amsterdam and also professor of experimental intensive care medicine at the University of Vienna, and is an expert on mechanical ventilation, and especially in those patients that are admitted in countries with lower or middle income. So I'm sure that he will explain or give us some ideas on how to treat and manage these patients with sepsis and acute respiratory failure. Marcos, it's your time now.
Thank you very much, Antonio, for this introduction. It's really a pleasure to be here today and to talk about indeed my favorite topic, which is mechanical ventilation in low and middle income countries. The title is suggesting I'm going to talk about ventilation or ventilator support in sepsis per se, but I have to disappoint you a little bit because there's not so much literature on this, whether sepsis patients should be ventilated differently or are being ventilated differently from patients not having sepsis. And also when we talk about low and middle income countries, I have to apologize because the literature on low income countries is quite scarce. There's not so much on low income countries regarding mechanical ventilation. So it's a little bit limited, but let me try to give an overview or to provide you some insights on ventilatory support in middle income countries per se. These are my disclosures. They do not affect what I'm going to tell you today. And the agenda I would like to have today is some words on lung protective ventilation, then talk about the patients or differences between patients in the different settings that I already alluded to on my first slide, so high income countries versus low and middle income countries, the ventilator management in these settings, and also finally the outcome. And in the end, I will provide you with some conclusions. So every lecture that is about mechanical ventilation actually should show something like this. So what is lung protection and why are we using that? I think over the last 10, 15, 20 years, we have learned a lot about mechanical ventilation, especially with regard to how we should set the ventilator. And it's not anymore a way of trying to improve gas exchange per se or normalize the gas exchange to the maximum level. In other words, to bring back physiology in a pathophysiologic condition, but more to protect the lungs against harm. And in some patients, it may result in non-physiological parameters in the end. And it's concerning several aspects. The most important you can find here on the right side of the slide. It's about using low tidal volumes. And when I say low tidal volumes, we often think it should be something like 6 milliliters per kilogram predicted body weight. We are slowly coming back from that idea. It should at least not be high tidal volumes, but tidal volumes of 6 to 8 and sometimes even higher in patients with a good pulmonary compliance is acceptable. but certainly not high tidal volumes. And we have a long discussion already about the level of PEEP that we should use in patients with ARDS or patients without ARDS. I don't want to open this discussion now, but I would like to stress that we should not use PEEP or high PEEP by default. There have been several studies that suggest that we should not do that. But if necessary, of course, we should use a certain level or a higher level of PEEP. And the new players on the block nowadays are markers or biomarkers or measures or parameters of intensity of ventilation, like driving pressure and mechanical power. And there is a strong feeling that we should try to limit the driving pressure and limit the mechanical power. But at the same time, we have to realize that sometimes this high driving pressure and mechanical power is intrinsic to the situation, intrinsic to the pulmonary condition. And it's not surprising that patients with ARDS are being ventilated with a higher mechanical power, for instance, as compared to patients not having ARDS. And it's the question whether you can really influence that in a way that it's benefiting our patients. Now let's try to focus a bit on the patient cohorts that have been out there in several studies. I'm not going to discuss all the studies, but we'll limit this discussion to the larger study that have been published over the last years, in which we can make a comparison between the different settings. Again, high-income countries versus low and middle-income countries. First of all, one study on sepsis patients. This is a nice study coming from an Asian group. It's an observational study lasting 4 days, and I show you here the baseline characteristics of the patients with, in Asia, the patients in low to lower middle income countries, upper middle income countries, and the high income countries. And although you get the feeling, looking at the p-values, that there are many, many, many important differences, I think the p-values are mainly different by the large number of patients. Because if you dive deeply into the differences that are out there might be statistical significant differences, but clinical meaningful differences are not so ominous. Yes, if you look in high-income countries, patients are often older. It's maybe because we admit older patients to an ICU in a high-income setting, but we also know that trauma patients, for instance, are more often present in low and middle-income countries in the ICU. So this is mainly driven by an admission policy, but also by the cohort of patients which is out there. And yes, also you can see that some of the diseases patients are having as co-diseases or comorbidities are different, mainly driven by the wealth within a country, like a higher BMI in high-income countries and more diabetes, etc. Now, if we focus on patients receiving mechanical ventilation, or I should say patients in studies focusing on mechanical ventilation, we see more or less the same. This is the LungSafe study. It was a large study. I think you all know this study, focusing on patients with ARDS, according to the Berlin definition at that time. And here you see more or less the same picture. You see that patients in high-income countries are often somewhat older and are having a higher BMI as compared to patients in other settings, but the other factors do not differ too much. Again, you see here impressive p-values, but I think the p-values are more driven by the numbers, and the differences that are out there in this study are not really that meaningful. This is another study. This is actually an individual patient data meta-analysis using the data of LungSafe, but also 3 other studies, one from Brazil and 2 global studies of mechanical ventilation. This analysis focusing on non-ARDS patients, and we see more or less the same picture. So yes, we see that there are statistical significant differences between patients, but the differences are not so small. The patients more or less look alike. Older patients or patients are somewhat older in high-income countries and having a higher BMI as compared to patients in low and middle-income countries. Now, what about mechanical ventilation or ventilatory management? And I focus here on invasively ventilated patients, not so much on NIV and the newer modes of respiratory support like high-flow nasal oxygen. If you look in LungSafe, you see something that we found already before in smaller studies, and what we also see in patients not having ARDS, and that is that tidal volumes are more or less alike, lower tidal volumes being used quite frequently in both settings, although lower tidal volume use is a bit better if we look at the high-income countries as compared to the low and middle-income countries. And this may also be a reason that we see a difference in the plateau pressure and in the driving pressure. PEEP is surprisingly a bit more often used in high-income countries as compared to the low and middle-income countries. And the only explanation I can give for this is that maybe in these settings, the people are, the healthcare workers are more afraid of using a high level of PEEP because it could result in hemodynamic compromise, which is needing then the use of vasopressors or the giving extra fluids to these patients, which is not always possible. And FiO2, the oxygen fraction, is going in the other direction, which makes sense. If you use a higher level of PEEP, you can use a lower FiO2 level. And of course, there are some other differences, like the use of prone ventilation or prone positioning, I should say. It's more often used in high-income countries as compared to the middle and low-income countries. And recruitments are surprisingly more often used in middle-income countries here in the graph you can see at the bottom on the right side. Now, if we focus on non-ARDS patients, so this is not a lung-safe study, but the other study I was using in one of my previous slides, non-ARDS patients not having ARDS according to the Berlin definition, you see that there is actually no difference whatsoever. Yes, there is a small difference in p-value, but if you look more closely to the numbers, it's not so impressive. So it seems like there is no difference in ventilatory support between these patients. There are surprising findings, however, and this might also be present in other studies than the studies I'm going to show you now. That is the difference in tidal volume size between female and male. Surprisingly, in almost every study where we look at, we see that females are receiving a larger or higher tidal volume as compared to males. We found that upper left in the lung-safe study. We found it in the PROVENT study. This was a like lung-safe study in patients that were not having ARDS. And then on the bottom, you see two other analyses of the PROVENT IMIC study. Here we see the same signal. Females are receiving a higher tidal volume as compared to males. And of course, this is not about being a female or not. It's about the height of a patient, because the calculation is depending on the height of a patient, and females are usually shorter than male patients. And we did some calculations. We modeled some of the data that we have, showing actually, depending on which cutoff you use as a safe tidal volume, either an 8 milliliter per kilogram predicted body weight or 7, and you can even go lower and say 6, you can see that the females are more or less often receiving a too high tidal volume based on the calculations that we use and based on the actual height. So this is a strong reason, I think, or a good reason to measure the height of patients and not estimate the height of our patients, actually, especially in low and middle income settings where persons are usually smaller than in the high income settings. Of course, there's also another important topic of mechanical ventilation that should be mentioned, that is weaning. These are the VeneSafe analysis. This is the first paper that appeared. Currently, there are many new analyses being planned or already on its way, but here are the main data. And what surprised me when I was looking at this data is that there is a quite long delay or large delay in the start of separation attempts in patients compared to the first spontaneous breathing activity, or whether they fulfill the weaning eligibility criteria that we all agreed upon in the literature. So there is a lot of delay. If you look at the reasons for delay in this observational study, it seems like it's mainly the deep sedation that is having a huge effect. So deep sedation of patients, apart from some factors that are related to the patient themselves, like frailty of a patient or the type of reason for which they receive mechanical ventilation, for instance, trauma patients, and I assume these were also neurotrauma patients, it's the deep sedation that makes a difference. It's not so much where you are on the world. It's not a difference that was with regard to middle income or rest of the world high income countries. Now, if you focus on how weaning then is done, and I show you now data from an Asian study again. This is a study performed a couple of years ago. Here you can see that there are many ways of weaning, different ways of applying spontaneous breathing trials and different ways of weaning. But don't get this message wrong, because if you look into the lung safe data, you can see that this is a reflection of what's happening on a global level. It's not typical for the low and middle income countries. This is what we see everywhere. But surprisingly, and this is important to note, in this study, if you look at the thresholds that the doctors were using, so what they mentioned as a threshold to start weaning, was quite different from what has been suggested in the literature. So many of these factors are not in our recommendations, but they are being used to start or not to start weaning. But again, here, we should realize that this is not typical for low and middle income countries, because we see the same in high income countries. So let me spend some minutes then on the outcome of ventilated patients in high income countries versus low and middle income country patients. If you look at this slide, this is again a study coming from Asia, from the same group as I was using data from before. If you look in the results panel on the left side, first idea is that there is not so much difference in mortality between the groups. But if we do a multivariable analysis focusing on the effects of the income status of a country, it looks like when you are in a poorer setting, so upper middle income or a low to lower middle income country, the chances of successful outcome or survival is much less. And this is a reflection of what we have seen in many other studies. I refer again to this one large study by Luigi Pisani, in which 4 studies were taken together. It looks like that the outcome of patients in middle income countries is worse compared to in high income countries. For instance, on the left side, if you look at the association between the SOFA score, so the severity of illness and outcome, especially in the lower SOFA score groups, you see that there is a higher mortality in the middle income countries as compared to the high income countries. And surprisingly, if you look at age, it is more or less the same up to the age of 15, but thereafter it goes in different directions, which are increasing gap, but opposite maybe of what you expect. It's a higher mortality in high income countries as compared to middle income countries. And we are not sure why this is. It could be that there is a stronger patient selection, especially for older patients, whether they should go to an ICU, yes or no. And finally, when you look at the right side of the slide, you see the inverse relation between the gross domestic product per capita, so the richness of the setting, versus the ICU mortality, with a lower mortality in lower middle income countries. These are data that are not published yet. They are under review at the moment. This is the PROVENT-COP database analysis. PROVENT-COP was individual patient data meta-analysis of 4, actually 6 large observational studies of COVID-19 patients. Here you see the presentation of 4 countries of which we had all the data available: Argentina, Brazil in red and blue, and the Netherlands in green and in purple. And although there are some differences with regard to mechanical ventilation, which was a bit opposite to what we expected as compared to what I showed you on some previous slides, the outcome of the patients is very, very different in the high income setting, so that's the Netherlands and Spain, versus middle correction, so propensity score matching, and other ways to match patients to each other to give a better picture of the outcome. It's surprisingly different, almost twice as high mortality. And we have had a lot of speculation about this with our colleagues from Argentina and Brazil. And one of the things that we were thinking about, it's maybe about selection of patients, which was much tougher, much stronger in the Netherlands and in Spain as compared to Argentina and Brazil. It may also be that patients come relatively late to the hospital in Argentina and Brazil compared to the Netherlands and Spain, and explaining some of these important differences in mortality. But it could also be, of course, the ICU care per se, which is reflected in other papers as well. This is one of my final slides. Here again, an Asian study in which we look at factors that were associated with outcome, now on a hospital or an ICU level, so not a patient level, and not surprisingly, the nursing to patient ratio and whether there was a medical team involved, yes or no, was really having a big effect on the outcome of patients. And this is what we understand and what we sometimes also see just being around in low and middle income countries. Having less nurses, having less doctors at the bedside means that the outcome of these patients are worse as compared to situations where you have more doctors or more nurses around. It makes sense, right? It's what we have found in many other studies. So in conclusion, before I give back the word to Antonio, I think the patient mix in high-income countries versus low and middle-income countries is not so different. There are some typical differences, but it's in fact not so different. Ventilator settings or ventilatory support, focusing on invasive mechanical ventilation, is also not so different. And in one of my last slides, the POV and COP analysis, I showed actually that ventilatory care seemed to be better in the low middle income countries as compared to the high income countries. Weaning is often delayed, but we see this happening also in high income countries at the same level probably as in low income countries. So we have to realize that there is more than just ventilation alone. It's the overall care that's really making the difference, or could really make the difference in outcome between high and middle income countries. If you are interested in having the slides for your own use, please send me a mail at marcus.j.schultz@gmail.com. I'm more than happy to share them with you. And with that, I would like to give the word back to Antonio. Thank you so much.
Thank you, Marcus, for your very interesting presentation. And I have a quick question to you, is that according to your data, can we mix patients from different income countries in randomized controlled trials in the future?
Well, the answer is yes, I think we can do that, but we have to pay attention to outcome differences that are driven by the factors that I mentioned before. So if in a situation like COVID-19, where there was really a big stressor for ICUs and a stressor for the whole community, I think it's not easy to put all the data together, for instance, in a randomized clinical trial. In observational studies, of course, you can do that. You can try to use propensity score to match patients to each other to see how the certain interventions of interest or certain factors of interest play a role.
According to your view, why is the explanation of the lower use of prone position in lower and middle income countries compared with high income? Because prone position is something cheap and easy to do.
Yeah, that's a very good point. And actually, I sometimes refer to what others have said before. And I saw the same when I was a bit younger as an intensivist. At the time when I was in training and a young intensivist staff member, we always had many nurses available or needed to have many nurses to prone a patient. Nowadays, we do that with much less people. With experience, you can do it with much less people. And in the end, and that's what we learned from the studies, and especially during COVID-19, it's really a measure that is reducing the consumption of work of the nurses at the bedside. So the data I showed you is coming from the LungSafe study. LungSafe, of course, originated from 2014, 2015. I think it's about time that we repeat LungSafe to do something new, to see how things have changed. And there are, of course, signals already, maybe triggered by COVID-19, that this use, the use of prone ventilation, really changed over the last years.
Okay, so thank you very much, Marcus. I think it's time to close this session, because in order to try to not to prolong longer this session and to give time for the next session. So thank you very much for all the speakers. That were fantastic presentations, and I hope that the audience will take the advantage of your recommendations and some messages to take at home. So thank you very much. Bye-bye.